Okay, we would also like to note that the views expressed by speakers and moderators during this event do not necessarily reflect the official policies for the Society for Maternal-Fetal Medicine. Next slide, please. It is now my pleasure to introduce our moderator, Sue Kindig. Sue is the Director of Women's National Health Nurse Practitioners Practice and Policy for the National Association of Nurse Practitioners in Women's Health. She's also a Women's Health Integration Specialist for SSM Women's Health in St. Louis, Missouri. Sue is a co-author on the Hypertension in Pregnancy Change Package, a key resource for the Action Forum. We're so happy to have her, and now I turn the Action Forum over to Sue.
Thanks so much, Taylor. And we're thrilled to have so many of you here. Right now, we have about 75 people on, and I am betting that by the time our speakers start, we're going to have at least 100. So thank you all for joining us today. I know it's really hard to get away in this sort of middle of August, getting people ready for school, getting that last vacation in. So thank you so much for joining us. And we have a variety of folks on this call. We have individuals that are in clinical practice, public health, academic researchers, community-based partners, so all across the spectrum. And every one of us touches women's health and hypertension in pregnancy and postpartum in so many ways. So we really do appreciate your engagement. And I just want to give a brief introduction to the purpose of the Action Forum and sort of an overview of what we've been doing for those of you who are new, or maybe a refresh for those of you who are joining again. So the purpose is really to address hypertension in pregnancy, and I'm going to add postpartum, through implementing evidence-informed strategies. And so we try to do that with the Action Forum to really highlight folks, what people are doing that are really innovative practices that we can all think about replicating, and to really learn from one another. So the Action Forum in May really provided insights into some successful transition of care models from pregnancy and postpartum care to our primary care and cardiology colleagues, because as you all know, hypertension just doesn't occur in pregnancy and then we send everybody home and they're fine. So we really are addressing that continuum here. And we recirculated the Hypertension in Pregnancy Change Package and the implementation survey. You can see the link on these slides so that we can learn a bit more about what's happening. Today, our focus is really going to be on a hypertensive collaborative learning collaborative, and we're pleased to welcome two clinicians who participated in the HPCP learning collaborative cohort. Next slide. But before we move on to learn more about that, the collaborative learning piece, we really wanted to start the meeting by taking just a few minutes to hear from you all, either by asking you to come off mute and put it in the chat, because we find that this really does help level set us. So for everybody on the call, either put in the chat or feel free to just chime in. Why are you here today? Why do you care about this topic? And where do you care so much that in the middle of August, you are spending an hour with us? And I can't see hands. So I'd say just give us some of your thoughts. You know, I'm seeing Jessica Ross put in, we want to better the care we give to our hypertensive moms. And I think probably that's echoed across most of the people here. I'm here, well, because I really believe in the project, but also because in my home state of Missouri, I'm involved in a large statewide grant looking to reduce maternal mortality. So every time I'm on here, I learn something that can really be implemented across our state. Let's see, other folks are saying, oh, they had experience with preeclampsia and pregnancy, so this is very personal. Someone is running the Health Ambassador blood pressure program at their space. People are wanting to be here because this is such a pervasive problem that impacts so many. Oh, I love this. Someone is here because they teach pregnancy and postpartum and still works in L&D, so wants to be really up to date on evidence-based practice because they're not only using it in their practice, but they are teaching other providers as well. Improving cardiovascular health outcomes for pregnant and postpartum women was a priority focus for Million Hearts. So we're hearing from our colleagues at Million Hearts, and that's a priority for 2027. So by 2027, I hope we have some really good outcomes. Hi, Diana Ramos. Hi, as California Surgeon General and an OBGYN, they're committed to reducing maternal mortality by 50% by December 2026. So we're going to have a lot of important data coming through. And I think if you look in the chat, you're going to see all of these wonderful reasons that people are taking part in this action forum, and I hope will continue to take part in this action forum. So, next slide, please. Okay, as we're all just so passionate about really helping individuals experience hypertension during pregnancy and postpartum, I'm really happy to be able to introduce you to a little more about what the Society for Maternal-Fetal Medicine is doing in this space. In June, SMFM hosted an in-person HPCP Learning Collaborative meeting with leaders who are working to prevent, identify, and treat hypertension in pregnancy and the postpartum period. So now I'm going to turn it over to our colleague, Lamia Ahmed, who will provide an overview of this collaborative. Lamia?
Thank you so much, Sue, for the wonderful introduction. Hi, everyone. I'm so excited to be speaking with you all today about our Hypertension and Pregnancy Change Package Learning Collaborative. Just to introduce myself, I'm the Manager of Public Health Initiatives at SMFM. And to tell you a little bit about SMFM, we are a nonprofit membership organization. We represent MFMs and other clinicians and researchers, both in the US and abroad. Who have expertise in high-risk pregnancies. And we lead evidence-based care in pregnancy by providing clinical and educational resources for our members to help them improve perinatal health outcomes. And then so to move on and share a little bit more information about our learning collaborative, we really designed it as kind of like a choose your own adventure based off of the different recommendation strategies from the Hypertension and Pregnancy Change Package. And so we recruited sites to participate in this collaborative based on having either demonstrated successfully designing or implementing interventions from the package. And some key factors that we looked at were MFMs who are active in the hypertension work and trying to get a variety of sites based off of geography, practice type, patient populations, et cetera. And really, we just wanted our to hear from our members what their current experiences are and, see if they can lend their expertise on the implementation science piece of it. So just to show you kind of the breadth of the different sites, you can see we had various sites across the US in a variety of academic and community hospital settings. And we're just very excited to have successfully had our first cohort. And so just to share about the Learning Collaborative, again, the purpose is to improve pregnancy and postpartum care and help patients across the pregnancy care continuum who are at risk of hypertension or have hypertension in pregnancy or postpartum. And then so to finally share some goals of the specific meeting that we had in the collaborative, they were to learn how clinicians implemented parts of the change package and really learn from them about the successes and challenges they've had, as well as any barriers or facilitators. We also want to develop a repository of tools and resources that we hope to have in the coming weeks and months. to share with people for how to help address, hypertension in pregnancy. And then we also want to be able to identify what individuals and teams can be developed at different sites to lead different work streams and project areas, and really overall help people who are trying to address hypertension in pregnancy figure out ways that they can strengthen their relationships and build partnerships amongst their clinicians, their community members. As we know, it's not just one group of people. It's not just MFMs. It's not just OBGYNs. This cross specialty collaboration is so critical and key. And so, figuring out how to invite and collaborate with nurse midwives, nurse practitioners, internal medicine, cardiology, exercise physiologists, doulas, community health workers, and so on and so forth. And so finally, just want to say thank you all for letting me introduce the collaborative. This is a photo of all the people that joined together in person earlier this summer. If you have any comments or questions about the collaborative, please drop it in the chat or email our team. For the sake of time, I would want to really give it over to our key speakers so that they can share their amazing work with you. So in the next slide, you can see we have two amazing people from two of our sites. So we have Dr. Brookfield, who is an MFM at Legacy, and after her presentation will be followed by Dr. Hirschberg from Penn. So Dr. Brookfield, please go ahead.
Thank you. I'm going to share my screen. There we go. You guys can see my slides, right?
Yes.
Yeah.
Okay.
Yes.
Good. We're good. All right. Thank you so much for having me here to present just a little bit of work on a project that we have implemented at Legacy Hospital. I spent a fair amount of time on the ACOG Committee on Obstetrics Clinical Practice guidelines, and I also practiced at Oregon Health and Science University for 7 years before moving to the Legacy Medical Group, which is a community-based practice in Portland. And there are definitely some differences between academic practice and community group practice. I think, though, it is important that we have some non-academic practices that were represented in this collaborative. We all have a role to play in identifying and treating hypertension, and most obstetric practices and MFM practices in the US are going to be non-academic in nature. So thank you again for having us. Let me see if this is going to let me advance. There we go. Okay. So I'm going to start with just some background information on the MFM group that I work with now. There are 9 MDs in the practice. We provide consultative and continuing prenatal care on an outpatient basis for high-risk obstetric patients in Southwest Washington and then also the greater Portland area. We have 4 ultrasound units. One is in Portland, Oregon, one in Silverton, Oregon, which is south of Portland, one in Mount Hood, Oregon, and then Vancouver, Salmon Creek, Washington has an ultrasound unit that's right over the Oregon-Washington border. In each of these sites, we scan many patients for anatomy, growth ultrasounds, biophysical profiles, Doppler studies. Many patients have primary OB care providers, but they don't have ultrasound services that are available in their groups. And so patients are referred to MFM for ultrasound for finding sometimes of oligohydramnios or suspected fetal growth restriction from some outside unit. They continue their routine care with their primary OB providers, and they're only seen with MFM for the ultrasound part of it. Our typical recommendation for conditions that warrant twice-weekly fetal surveillance in pregnancy is the alternating non-stress test and biophysical profile. Patients who are followed for fetal growth restriction do need umbilical artery Doppler assessment every week, and so the BPP makes sense to attach to that ultrasound visit. There might be some clinical scenarios that are associated with severe hypertension that are acceptably followed with non-stress tests twice weekly. But for a variety of reasons, one main one in our region is just clinical capacity for some of our referring OB groups. The practice, again, is usually this alternating non-stress test and biophysical profile. And one downside to the alternating NST BPP approach is that blood pressure is not generally checked at an ultrasound only visit. So before the intervention that I'm going to talk about and focus on took place, there were patients at risk for severe hypertension who were only getting a blood pressure check with their primary OB provider at the time of a non-stress test and not at the time of coming in for BPP Dopplers. The motivation for implementing this change initiative was essentially a missed opportunity to potentially have intervened sooner for a patient who ultimately presented with an IUFD or fetal demise. There was a patient who was referred for MFM ultrasound only due to suspected fetal growth restriction on an outside ultrasound, and growth restriction was confirmed by our office on a Thursday, and abnormal Dopplers were reported. The ultrasound report was signed. The patient was scheduled for their follow-up, which would have normally been a non-stress test with their primary OB on the following Monday, and then follow-up BPP Dopplers again with our group the next Thursday. And prior to that follow-up ultrasound appointment and prior to the follow-up with the non-stress test with their primary OB, the patient presented with an IUFD and preeclampsia with severe range blood pressures. And so our group reviewed that case and decided to implement blood pressure checks for all patients referred to our ultrasound units from other OB providers where an ultrasound was scheduled for an etiology or where there were new findings that carried an increased risk for preeclampsia or severe hypertension. So when Megan had contacted me about this SMFM initiative, it felt like this was an opportunity to collect some data like a QI project just to see if by making this change, we would pick up additional cases of hypertension and make a difference. This is just a slide to give you an idea of how many patients we might need to do an extra blood pressure check on each day in our ultrasound units. So of the 4 clinics that are listed here, these all have an in-person MD on site reading ultrasounds and reviewing them with patients. There are between 1 to 4 patients at each site being scanned each day, specifically for fetal growth restriction that would not have an MFM consult attached or requested for that appointment referral and would be just for ultrasound only. We also do a lot of remote reading, but we are not factoring those patients in. We only implemented this change where there's an in-person MD who can provide counseling and follow-up for these patients. So we decided as a group to implement the change in January of 2025. This is now the 8th month of implementation. I'm going to show you data that really just encapsulates the first 6 months of the implementation before we had the HPC meeting. And though all 9 MFMs were participating in the implementation and still do, there were really 2 of us, Kelsey Pinson, whose name I had on the opening slide, and I, who recorded data when we were staffing ultrasound at any of the 4 mentioned locations with an in-person MD reading ultrasound. So we recognize that the data that we're showing you is just from a convenience sample. It was just 2 MFMs dedicated to writing down what we saw. But again, the idea was to capture ultrasound patients who are at risk for preeclampsia and severe hypertension, but who otherwise would not have had a blood pressure check at an ultrasound-only visit. So patients that were eligible, we decided for blood pressure checks at these ultrasound-only visits were patients getting BPP Dopplers for known fetal growth restriction, patients getting a BPP for oligohydramnios, patients who were getting a growth ultrasound where there was a new finding of FGR or oligohydramnios at the time of that scheduled ultrasound. And then any patient with known gestational hypertension or preeclampsia without severe features that was being managed as an outpatient. Of note, the MD does not do a lot of deep diving on the charts before these patients come for ultrasound, but our ultrasound techs are very good at prepping charts to make sure things like gestational hypertension or oligohydramnios are in the indications field for the ultrasound so that it's pretty easy for us to identify these patients when they come through. We made a slight change to the process for intervention initially presented after the Learning Collaborative. And the process I have listed here was what we were doing when this data I'm going to show you was recorded. At the end of an ultrasound, the sonographers would present cases for those scenarios we talked about to the MD, and then the MD would go and talk to the patient and would have the nurse go into the ultrasound room to do a blood pressure check for those patients. If the blood pressure was normal, the patient was free to go and return for the follow-up that we scheduled them. If blood pressures were greater than or equal to 140/90, then the RN would notify the MD and the MD would decide the next steps. And next steps really depended on the severity of blood pressure that was ascertained, any symptoms the patient had. It might have included, though, a lab draw or further evaluation on labor and delivery. And then blood pressures for all of these encounters were recorded in Epic under the actual ultrasound encounter. And the patient's primary OBGYN was notified via phone or Epic chat, depending on the acuity and what mode of communication some of our referring groups prefer. So the change that we made after presenting this at the Learning Collaborative was just that the techs now go and just get the nurse right away to do a blood pressure check to tell patients that we screen for hypertension and our high-risk patients. It was brought up at the Learning Collaborative that perhaps, if we're delivering news of fetal growth restriction for the very first time, that could be stress-inducing, and maybe we were capturing some blood pressure elevations that weren't necessarily related to preeclampsia, but were more just the stress of getting bad news. So that was the rationale for kind of changing things up with the order of checking blood pressure versus the MD going and talking to them. And this change has been fine in the process. Patients don't seem to flinch when we just say it's our process to take blood pressures on higher risk patients coming through the ultrasound unit. So over the 6 months that we implemented this change, Kelsey and I recorded 63 encounters, and I want to specify these are encounters, so patients who are coming in weekly for known growth restriction for their Dopplers BPP. Some of the data that we'll show you a screenshot of incorporates the same patient coming for a subsequent ultrasound, each week. So 63 encounters over those 4 ultrasound sites. The data was recorded. Indications were mostly for FGR. There were some patients with oligohydramnios, some being managed as outpatients for gestational hypertension. We captured 9 events of elevated blood pressures greater than or equal to 140/90. And there were 2 patients who were sent to labor and delivery and were delivered within 24 hours. Their blood pressures were so severe. This is just a sample screenshot of data that we recorded in a simple Excel sheet on our SharePoint that had the data of the encounter, which site we were staffing, the indication for the ultrasound, and then any notation of abnormalities or follow-up that could be recorded. I think it's important to note that aside from what I just showed you and talked about, there were other episodes of hypertension and preeclampsia that were captured by our partners. So that data wasn't recorded, but I can just tell you anecdotally, we have found a lot of hypertension out there in patients that are coming for ultrasounds with indications that can be associated with severe hypertension. Patient experiences haven't been formally evaluated. I would say that generally they are good. We don't we have an occasional patient who might be annoyed by the process. They're usually patients who were referred in from community midwifery, and they might be planning an out-of-hospital birth. They're generally, coming to grips with an in-hospital delivery in these situations, and they're not really excited about coming to MFM for ultrasounds anyways. But we've captured a lot of elevated blood pressures out there, and we do think that this process seems to be making a difference. I think the successes speak for themselves in the data that's presented. Challenges and barriers include just devising a unified way or algorithm for patient follow-up after elevated blood pressures are identified. We do have so many different referring OB groups that they may want those blood pressures to be communicated in a certain way to them. They may want the follow-up to be scheduled in a certain way. We presented an algorithm at the collaborative meeting and are in the process of final approval. But our plan is essentially to have our algorithm for what to do when we identify a blood pressure of greater than or equal to 140/90. And we are going to disseminate it to all of our referring groups and just say, hey, this is what we're doing in our practice now. This is how we're planning on dealing with elevated blood pressures, and this is how it will be communicated to you and what our recommendations are for follow-up, so that it's just out there that this is standard for us, and how the flow for follow-up will go after blood pressures are taken. It can be challenging sometimes when our hospital system is on divert or low on staffing if inpatient services are needed. Luckily, at each of those 4 units, we do have labor and deliveries that are right there. So if we really have severe range pressures that warrant, IV antihypertensives, we have a place to send patients. And in general, I would say our charge nurses are great about just understanding that is a OB triage that really can't be punted anywhere else and has to be dealt with. And just, again, devising these clear algorithms for the process to follow after elevated blood pressures are detected, and then disseminating that to the private groups that refer to us. No additional funding has been needed for this implementation. We do record the blood pressures in the EMR for documentation purposes, and we're trying to keep track of any additional nursing resources that are being used in this process in the event that we do need to carve out additional FTE for this. But generally, it takes less than 5 minutes for our nurses to take and record the blood pressure in the chart. There is some additional MD time that just depends on the extent of concern in the setting of elevated pressures, but it's not really any different than other surprises that we encounter in the course of our day in ultrasound. And then in our group specifically, something unique is that we do have a nurse there on site because there's a clinic running concurrently. We have the ability to have the nurse in clinic 1 to 4 patients at each of these sites. Doesn't sort of disrupt their day at this point significantly, so we can pull them to come and do the blood pressure. And then if there's something that needs a lab draw, we have the resources to do that lab draw in clinic. And communication between our ultrasound techs, our nurses, and our doctors has been very smooth overall. And yeah, this is just, again, acknowledging that this has been an easy thing to implement because we do have RNs in clinic. That may not be the support staff that's present at all ultrasound units in the US. So that could be a challenge for certain groups to implement this practice if they don't have trained staff to take blood pressures. Or something else that came up in the learning collaborative was that not all sites are able to have a lab drawn on that site, even if it's not by a nurse in the unit. There might be insurance coverage that dictates where a patient needs to have their lab draws, and so it could be a little bit clunky if you're having to send a patient elsewhere to get labs done and who's going to follow the labs up, et cetera. So there are some challenges, but the unique setup of our clinics, I think, has allowed us to really implement this without issue. And that is what I have for you. I'm happy to take any questions.
Thank you. I'm not seeing any questions in the chat. And Taylor, I don't know if y'all are seeing any hands up, but while we're waiting for that, I'm going to start off with a question. You know, just from attending other SMFM meetings and so forth, it seems that the availability of maternal fetal medicine consults and ultrasounds remotely, holds a lot of potential and is growing. And I'm wondering if you might be able to speak to how this program might lend itself well to something that was done via telehealth.
Yeah. I mean, I think honestly, I put in the ultrasound breakdown that we do a lot of remote reading, and we haven't specifically recorded data for those sites. We try not to have the patients with known growth restrictions scheduled in places where it would be remote reading, specifically because there is the potential to have to talk about a new finding that might change delivery timing or surveillance, right? But I do think as long as you have someone skilled at taking blood pressure, who is present on site wherever these ultrasounds are being done, there really is the capacity with telemedicine still to identify these patients with hypertension and to intervene. Um, I think that would require sort of further focus on that algorithm that we talked about, like what you do in that situation. But I know our group would certainly, if there were severe range blood pressures that we're seeing, we would have a nurse who's able to check the blood pressure, identify that and get them added on, as you said, for a televisit, rather quickly. And these things do take time. It doesn't take that much time to check the blood pressure. And it's, just a few times that you're going to find something that's severe range that needs to be dealt with. But there are ways to add these patients on for telehealth visits, I think, and get them adequate follow-up. The only time I can see that would be overwhelming is if you have a remote site and this is, like 20% of your population is there for FGR, right? Because then you really need like one dedicated person to follow that. But I think in general, that's not how most ultrasound units are, that there are just a sprinkling of these patients. And as you could see for the two patients that got delivered within 24 hours, it can make a big difference. It can make a huge difference. So if you're only, having to deal with that in a few patients a day, telemedicine does have a place. You just have to figure out in your algorithm, if you find a severe range pressure, where can that person get their labs, and what is the most acute care unit where they can go to for treatment if it's needed.
Thank you.
Pardon me.
Thank you.
Mhm.
I'm not seeing any other questions, so I think what we'll do is go on to our next speaker, and we're going
Sorry,
to have, oh, yes, was there one?
sorry. Yeah, there is a question. I can
Oh,
read
I'm
it to
sorry.
you. No,
Thank
no,
you.
you're fine. I think it was only sent to me.
Ah.
This question, it says, recognizing that hypertension may show up in immediate postpartum care, do you have a process that follows patients when they are discharged and then readmitted?
Yes. So for patients that we know during their hospitalization have had severe hypertension, those patients are followed up for a blood pressure check at our office. Usually it is the MFM office because of the fact that they might end up needing medication or medication adjustment. So those patients are followed up for a blood pressure check within 72 hours in our actual MFM office. if blood pressures are sort of newly discovered to be severe range postpartum, or patients are calling in with new symptoms that are concerning for postpartum hypertension, those would get triaged still on the inpatient side of things. But for patients who have had known severe range pressures in their intrapartum course, we do have them follow specifically with our MFMs within 72 hours. One thing that came out of this collaborative, I don't know that it's going to be addressed in detail in the context of what we're talking about today, but I think that there are some places outside of my current community-based practice that do deal with the postpartum follow-up a little bit better. It's a more well-oiled machine, I would say, than what my group currently has. But patients are sent home specifically with blood pressure, cuffs, and there are very defined algorithms on adjusting their medications and their follow-up. And I do think as part of this change package, you will be able to see some of the other groups and the way that they deal with following postpartum hypertension and deciding how to adjust medications or who needs readmission. That will all be in there. And it will probably have processes in there that I think are smoother than what I could tell you my specific group does. But yes, we always will see those patients at 72 hours to decide whether we need to start or adjust medications.
Great. Thank you so much. Thank you so much. And thanks, Lamia, for jumping in there with that question. We will have more time after the next presentation if anyone has a lingering question for Dr. Brookfield. But in the meantime, I am going to turn this over to Dr. Addie Hirschberg. Dr. Hirschberg is an associate professor of clinical obstetrics and gynecology at the University of Pennsylvania Perelman School of Medicine. And she also serves as the director of obstetrical services at the Hospital of the University of Pennsylvania. So welcome, Dr. Hirschberg, and take it away.
Hi, good morning or good afternoon, wherever you are. Thanks for having me. And I just wanted to say, it was a really great experience to be part of sort of the collaborative. We've worked on starting to implement blood pressure checks with our growth restriction ultrasounds, since the collaborative. So I think just a great example of getting a lot of great minds together in a room and, learning from each other. So I'm here to talk today about our blood pressure monitoring program for postpartum hypertension. It's something that has been in the works for almost 7 to 8 years, but has ongoing improvement, and sort of just here to share sort of our processes and ways that, I think other programs can develop either similar things in different sort of high tech and low tech situations, which is something that we talked a lot about at the collaborative as well. So you can skip the next 2 slides, just the outline, and spend the beginning talking about our intervention. So as most people on this talk know, it's recommended that patients with hypertensive disorders of pregnancy are supposed to have blood pressure checks sometime around 72 hours, and again 7 to 10 days postpartum, given the risk of persistent hypertension in the postpartum period and sort of the fluid shifts changes that occur at 3 to 5 days postpartum, with risk of severe hypertension after patients leave the hospital. Next slide. When this recommendation came out, and still even to this day, there's not a ton of guidance on how to get this blood pressure check, appointment. We tried to have specific clinics for these visits. And, when this first came out in 2011, 2012, you can see here the show rates when we asked people to come to the office for those in-person visits. The show rate was pretty poor, with 42.5% for non-Black patients and 24% for Black patients. You can click, you'll see we tried many different types of strategies to try to improve blood pressure ascertainment. We tried expanding office hours, letting people show up, walk in. We called them ahead of time to remind them. Nothing really improved over the course of the years. And in fact, as you can see, our attendance actually decreased despite all of these other interventions. Next slide. So we realized that this visit wasn't successful. And after interviewing a lot of patients and seeing that there were just so many barriers to come to the office, and a lot of people were frustrated with the transportation and the parking and the costs, and they're still recovering from their delivery, and they have to go to their pediatric visits, all these barriers to in-person care that we know exist for the 6-week postpartum visit are even more prevalent right after someone leaves the hospital. And so in talking to the patients, we thought that we would trial a text messaging program where we provide patients with a blood pressure cuff and ask them to check their blood pressure and send us their data. You're good. So this is data from an initial pilot project that we did, in which we tried various ways to text patients and see if we would be able to actually get the blood pressure information if we sent them home with a cuff and asked them to check it. And you can see sort of different, we did several PDSA cycles to try to figure out what information we could get. And ultimately, we saw that over 85% of patients were sending in blood pressures on average when they were given a blood pressure cuff to send home and texted to remind to check their blood pressures. Next slide. And you can click here. So compared to the patients who were asked to come to the office, only 15% of patients in our pilot were asked to come to the office. When we sort of did a low scale pilot, 85% of patients texted their blood pressure from home. And so we figured that this was worth investigating a larger scale platform in which we could take care of a large volume of patients at any particular time without having to sort of individually text patients. Next slide. So in 2000, and I think it was about 2015, we decided to create an entire postpartum hypertension bundle. One of the things that we realized in patients who did come for their blood pressure check was that not many of them were started on blood pressure medications in the hospital. We were having a lot of inconsistent care in when patients were started on medications and what blood pressure medications they were started, as well as differences in initiation of medication when patients were seen in the office. So we wanted to standardize our inpatient and outpatient hypertension protocols. And then we worked on developing this large-scale remote blood pressure monitoring program. Next slide. So our bundle was created to standardize postpartum care and follow-up for patients with pregnancy-related hypertensive disorders of pregnancy. Next slide. And we just sort of created parameters in which patients would all be started on an oral antihypertensive if the blood pressure was over 150 or 100, which is what was recommended by ACOG, and obviously still up for debate. And we sort of provided all our providers with recommendations of which blood pressure medications to start, how much time to give before increasing the medication. And we also made sure that all of our patients were going home with a 5-day course of Lasix, given increasing data that a short course of diuresis can decrease the risk of severe hypertension. And so all of our patients who have hypertensive disorders.
Dr. Hirschberg, it seems like we're having a few problems hearing you. You just cut out for a second. We hear you now, but
Can you hear me now?
yes, but
Okay.
it's cutting in and out.
Next slide. This is like my third computer that I'm trying, so I apologize. And then the other part was figuring out how to get the blood pressure information after patients leave the hospital. So this was our development of a scalable automated platform. We really wanted to focus on a platform that was automated and bidirectional, meaning that patients would get immediate feedback after they sent in their blood pressures. We also needed a system that would immediately notify the provider for any patients with severely elevated hypertension. And it was important that the platform was HIPAA compliant for patient privacy. We were fortunate enough, next slide, to have a research-based platform at our hospital called Way to Health, which was able to provide a lot of those requirements and give bidirectional automated HIPAA compliant texting. We decided to give our patients blood pressure monitors before they left the hospital. I saw someone from Omron was in the chat who was hoping to give blood pressure monitors to everyone, but we were providing patients with cuffs before they left the hospital, and we made sure that patients had unlimited text messaging capabilities. Next slide. Patients received program-specific information before they left the hospital. So they were instructed on how to check their blood pressure at home. Then they were instructed about signs and symptoms of preeclampsia and how to text in the results. So, they were given a cuff, they showed how it would read to them, and we taught them what numbers to sort of text back into the program. One of the things that was important to us was to keep this purely text message based and not use any Bluetooth or other wireless requirements, because prior data from our institution suggested that more patients had sort of basic text messaging than access to sort of Bluetooth technology. Next slide. So this is examples of the patient and provider view. So patients receive twice daily text messages to check their blood pressure. They text back the value. If it's normal or a little bit elevated, they get information on that. If it's severely elevated, they're instructed to check their blood pressure again, and simultaneously a provider on the receiving end gets a message through our program phone that the patient had an elevated blood pressure, and then that leads them to contact the patient to figure out next steps. So this is our algorithm. We use currently parameters of 140/90 and less to be normal, and 160/110 for an immediate prompt to the provider. So if you click forward, you'll see that. And then in the middle, patients are instructed that their blood pressure is a little bit high, but the provider reviews the blood pressure sort of once or twice a day, and patients who are in that sort of middle time frame get a phone call, not immediately, but at some point during the day to talk about whether or not we should start a blood pressure medication. Next slide. So this is an example of a log through the platform that's run every day. You can see sort of on the right-hand side all the different blood pressures that come through. And so this would be an example of if someone was in the 150s/100s, we'd probably give them a call at some point during the day and talk about starting a blood pressure medication. Next slide. We also have this nice color-coded view that allows us to see which patients are sort of in the clear, which patients are sort of teetering, needing medications, and which patients are responding to medications over the course of their monitoring period. Next slide. And an important part of our program was to also make sure we had long-term follow-up. So we do have instructions in our inpatient protocol on who needs a cardiology referral, whether or not they go to a cardiologist or a primary care doctor. The more severe patients are instructed to follow up with cardiology, and then the other patients are instructed to follow up with their primary care doctor, given the association between preeclampsia and long-term cardiovascular risk. Next slide. And so outcomes, we actually did a randomized control trial that was presented at one of the pregnancy meetings, and I think it was 2017, about the differences between patients who were randomized to office visits versus text messaging, and showed that this program was able to get blood pressures in over 90% of patients. It decreased emergency room visits, hospital readmissions for hypertension, and actually increased 6-week postpartum visit attendance rate as well. So this was important information for us to be able to get support in our department to make this program the standard of care. Next slide. We also showed that it reduced disparities in blood pressure ascertainment. So patients who were instructed to come to the office, there was a clear difference between non-Black patients and Black patients, where 70% of non-Black patients came to the office compared to a third of Black patients. But you can see that regardless of race, over 90% of all patients were sending in blood pressures via text messaging, suggesting that this sort of at-home patient-centered approach overcame a lot of the barriers that seem to be affecting our Black population more than non-Black patients. Next slide. We also looked at long-term outcomes. We were able to partner with a payer and look at outcomes over a 6-month postpartum period, and it showed that patients who were enrolled in Heart Safe Motherhood, when compared to patients who delivered at hospitals without Heart Safe Motherhood, or patients who delivered in our hospitals before Heart Safe Motherhood existed, had less long-term individual outcomes, such as stroke and cardiomyopathy. Next slide. And as intended, we actually were able to prove that sort of this bundle increased cardiology visits and specialty visits and decreased emergency room visits and inpatient readmissions for hypertension. Next slide. So overall, our program, in addition to other programs that exist that we learned about in the collaborative that use remote monitoring, helps achieve the ACOG standard, reduces readmissions and emergency room visits. We were able to decrease our length of stay by having short-term, follow-up with blood pressures via text messaging, and improve patient satisfaction. Next slide. So given the results of this, we were able to implement Heart Safe Motherhood at all the Penn OB hospitals. Next slide. You can see that over the course of the years, we implemented this at the 5 different hospitals over time, and we have, several thousands of patients enrolled with many hundred to 1 million blood pressures. And you can see that sort of the engagement of patients with at least one blood pressure has been pretty consistent to the trial, despite sort of now being in real practice now in some sites for 7 years. Next slide. And importantly, when we look at our cardiology visit rates for the referral, this was further proof. We were able to show that telemedicine is actually really good for our cardiologists as well. And when they were able to provide telemedicine visits, especially during COVID, more than 70% of patients attended those visits compared to 30% of patients who wanted in-person cardiology visits. And our cardiologists are very happy with implementing telemedicine for long-term preeclampsia counseling and follow-up as well. So barriers and challenges, one of the things that I think is clear that, having postpartum, blood pressure cuffs is relatively low cost. They're easy to use. They empower the patient and reduce the need for patients to come back to the office. And I think we've gotten tons of blood pressure data for postpartum, blood pressure trends through various remote monitoring programs. I think one of the challenges are the limitations. There aren't a ton of validated cuffs in pregnancy, and people question the accuracy of readings, especially in pregnancy or in the immediate postpartum period. There's lack of guidance on how often we should be asking patients for their blood pressures and when to check them. And really, you need to have people on the receiving end who are willing to manage these blood pressures. We have nurse practitioners and MFM physicians, but there really needs to have that infrastructure of who is going to be managing the blood pressures, and then paying. Who is going to pay for the cuffs? Who's going to pay for the time it takes to monitor the blood pressures? And so really working on reimbursement for the cuffs in pregnancy to ensure that's a key part, right? The patients need to go home with the cuff to get the information in a timely fashion. And how can we get reimbursed for the cuffs in addition to the blood pressure data that we're getting? Next slide. These are just still unknowns. There's just not a ton of data. Like, who should be getting remote monitoring after delivery? Should it be everyone? In an ideal world, yes. But really right now we're just focusing on high-risk patients. Who is managing the blood pressures? Are they generalists, MFMs, cardiologists, nephrologists? And I think like the how, are we using automated monitors, wireless or Bluetooth technology, or keep it simple with text messaging compared to app-based programs? I think when we start to increase, like I mentioned before, one of the things that came out in the collaborative was like how to ensure that we're not widening the disparity gap by a lot of technology, and how can we implement similar things in low resource settings who don't have, access to a lot of the interesting, innovative research programs that are available at academic institutions, and how to simplify this in like a paper and pencil form when the patient really just needs the blood pressure cuff. Again, this is just a thing I wanted to highlight, like the question of technology and equity, and you can click through this, but our data and US data suggests that more people have smartphones, and that was really important for us as far as why we chose to do a text message based approach. Next slide. So I did want to mention low tech options. I alluded to them previously. I think the key, people are looking at self-monitoring programs, patient education, giving them parameters of when to call if you can't have access to like this automated text message-based system. People who don't have blood pressure cuffs, we do instruct patients if their cuff isn't working to go to the pharmacy for a free blood pressure check, using paper logs and using things like MyChart to be able to provide that patient-provider interaction after delivery if you can't have access to a program like this. And I think it's funny, someone asked what approaches do you have to engage patients? And so I do have a slide here on how to get 100% patient engagement, because 85% is good, but obviously the goal is 100%. And we actually interviewed patients. You can go to the next slide. We divided our patients into sort of non-users, patients who sent in less, no blood pressures, minimal users who sent in at less than 25% of the requested blood pressures, moderate half, and super users that sent in over 75% of the blood pressures. And despite all of our focus in the hospital on education and how important this is, and the risk of preeclampsia and postpartum morbidity, every single patient considered this low priority in the postpartum period, and really was focusing on their baby. What we did notice a difference in is that the non-users said their postpartum transition to home life was so difficult. And the super users all said they had an easy postpartum transition. And I know this focus is on, hypertension, but I think it just highlights the importance of, providing support for our new patient, new moms postpartum in order to allow them to take care of themselves, because that was the only thing that really came across in our patient interviews. Next slide. We always get the question of funding. So we have ongoing discussions with payers for reimbursement for the blood pressure monitors. A lot of our payers are paying for them prenatally, but we actually have a lot of discussion in the state of Pennsylvania about universal blood pressure cuff coverage for all pregnant patients, once per pregnancy, with hope that it'll pass sometime in the fall. And we're investigating sort of different telehealth codes for remote device monitoring. And we're hopeful that with ongoing research collaboration and cost analyses, that many places will feel like investment into programs and even just supplying the blood pressure cuff is cost saving on the back end when we are reducing readmissions and morbidity and mortality.
Thank you, Dr. Hirschberg. That is a lot of information, and we are really cutting it close on time. So I'm just going to kind of go to the chat really quickly. Someone had put a question in about trying wrist cuffs, and there is a question, there is an answer in the chat about wrist blood pressure monitoring needs to be held at the heart level to ensure accurate blood pressure measurement. So I think signaling if you are using wrist blood pressure cuffs, there is an art to that as well. And also there is a nod to Omron if you are looking to do a clinical study and need special pricing, Jim has his email in there. Now for questions really quick. I just wanted to go back up to one of the questions that was, what approaches have been successful to engage patients in their blood pressure management? Many care teams are struggling to get their patients to engage in regular blood pressure measurements and to adhere to follow-up appointments. And that's a question for both presenters. Do you both want to weigh in on that?
I was trying to allude to that a little bit. I mean, we spent a lot of time in the hospital emphasizing the importance. We try to provide them with the materials they need to check their blood pressure. And within our program, if patients don't send in a blood pressure, those patients get within the algorithm, there's special messaging and text alerts that go to those patients telling them that this is really important. Please check your blood pressure. We haven't heard from you in a few days. So we really just try to maintain that constant contact. And for patients who we know about from the hospital who may be at even higher risk, reach out via phone call. I think a lot of it is just education and talking to the patients about what those barriers are and figuring out ways to overcome them. For us, it was giving them the cuff, letting them do this from home, but also asking them what the challenges are, if it's a language barrier, if it's transportation, if it's childcare. A lot of places still have child care, like don't allow child visitors even, since COVID. And if that's the issue, like we allow patients to bring their babies and things like that. So making it more friendly for the patient and figuring out what the issues are.
Yeah, Dr. Hirschberg, do you have any comments on that? I know you talked a little bit about patient engagement and the strategies were kind of equivocal, if I'm remembering correctly, in terms of their effectiveness. Do you have anything to add that you may have noticed in your practice?
Can you guys hear me?
Yeah.
Yes.
Yeah.
Okay.
Oh, sorry. That was Dr. Hirschberg.
I'm sorry.
No, that's okay. That's okay. The only thing I was going to add to what I just said too is, our group, I would say for the blood pressure follow-up is one of those more like low tech sort of resource groups. And one thing we have been able to do because access to a cuff has been a big issue. We did partner with American Heart Association and have a loaner cuff program in our clinic, which we have utilized heavily, I would say, in getting patients cuffs. It is on the outpatient side, and so it still does kind of require some coordination for whoever the MFM is sort of rounding to find those patients that are ready for inpatient hospital discharge to get the outpatient cuff assigned to them to go home with. But there are some of these, groups that you can partner with to try to help with cuff access. For our patients, that has been voiced as like the biggest barrier. But yeah, I mean, that transition to postpartum care, postpartum care is really like there's all of these different pockets, I feel like, of postpartum care that contribute to whether patients are able to execute and actually take their blood pressures even when they have a cuff. And so just kind of paying attention to the global postpartum health is important for these patients.
Thank you. And we are at time. So I'm going to ask for the last slide. And if there are any additional questions in the chat, I didn't see any, but it's kind of hard to keep scrolling. So if there are any additional questions in the chat, we'll take a look at that and try to get answers for you. In the meantime, thank you so much. We are thrilled that you have joined us. If you have any questions about the Action Forum, please email us at hypertension@smfm.org. Don't forget about that hypertension and pregnancy change package implementation survey. We would love to hear from you. And please know that follow-up is going to include the meeting, recording, the resources, and information about registration for our next action forum, which will be on November 12th at 2 o'clock Eastern. Thank you so much for joining us. And we hope you have a great rest of the summer, and please keep in touch and let us know how you're utilizing the change package and implementing your hypertension in pregnancy and postpartum programs. Thank you all.
Thank you.
Oh, someone's is asking to have the survey link dropped in the chat. Is that something y'all can do?
Yes, I'll put it in the chat now. Thank you.
Thank you. There are a lot of really, really good chats coming in right now about, concerns about people using their benefits, losing Medicaid benefits and so on and so forth. So these are something we will also look at for future forums.
And we will also send out the survey in the email so that if anyone doesn't get it, they'll be able to do it then. Thank you all so much for joining us.
Thank you.